Hello guys, welcome back to my YouTube channel. Today we are continuing the topic hypokalemia. Now hypokalemia is a condition in which the potassium levels falls below 3.5 milliequivalents per liter, and the causes of hypokalemia are first redistribution into cells, that is the potassium ions redistribute into the cells. Example in metabolic acidosis, as we know, the hydrogen ions come inside the cell because hydrogen ion increases because of the pH decrease, and then therefore the potassium is redistributed into the cells. Now there can be hormonal reasons due to insulin beta 2 agonist or alpha antagonist drugs. Now in anabolic states like vitamin B12 or folic acid, or in total parental nutrition. Other cause could be increased loss. Example renal losses like primary hypoaldosteronism, secondary and renal tubular acidosis, diabetic ketoacidosis, and Cushing syndrome. The GIT losses include the nasogastric suction, diarrhea, vomiting, or decreased intake is another reason, which includes starvation, clay ingestion, or transcellular shift is also another reason. Now clinical features are fatigue, myalgia, and lower extremity weakness. Neuromuscular, to be specific, neuromuscular features are rhabdomyolysis, paralytic ileus, and cardiovascular abnormal ECG, arrhythmias, orthostatic hypotension, decreased cardiac contractility, and myocardial fibrosis. And another is also hepatic encephalopathy. Now we'll talk about the most important part, that are the ECG changes. So in ECG changes, there are appearance of U wave, which makes it distinguishable, flattening or inversion of P wave. As you remember guys, in hyperkalemia there was peaked T wave with increased amplitude. As you can see here, peak T wave is increased amplitude. And ST segment depression, prolongation of QT interval and PR interval, and widening of QRS complex, and U wave that is appearing is very prominent. So the prolonged PR interval and widening of QRS, these are same as hyperkalemia. If you remember, this is all about the hyperkalemia causes and the ECG changes. Now we'll come on the topic anesthetic implications. Anesthetic implications are ECG monitoring should be done, glucose free solution should be administered, and hyperventilation should be avoided. Why? Because hyperventilation increases the hypokalemia. Avoid that is what are that is. Now treatment is, so first of all, what is the like in treatment, we have to remember one thing, that until and unless it's not severe, we should correct it by oral route. So the increased we have to increase the potassium intake with fruits such as bananas, dried fruits, and melons. And if we have to put it on the IV therapy should only be done only when the potassium levels fall below 2.5. IV KCL will be used on an IV pump or controller. Now we have to monitor the input output and minimize the ongoing losses. 15% KCL in 10 ml ampule. We have the 10 ml ampule of the KCL in where it is 15%, and it contains 20 milliequivalents of potassium, which is almost around 1.5 gram KCL. And we have to also use isotonic saline, and the increase should not exceed 8 milliequivalents per hour via peripheral vein. We have to remember this thing. And it is safer to correct potassium via oral route, and dextrose should be avoided.